Good evening, everyone, and I welcome you to today's program on minimally invasive surgeries missed for treatment of benign enlargement of prostate. And I would like to, in the beginning, welcome our president, Dr. Lalit Shah, and request him to give a few comments. Then I would like to request Dr. Uttam Mete, our secretary for Urological Society, to give his comments and then hand over the program to Rohit, Dr. Rohit Joshi, who is who will be the convener and who is going to conduct today's program. So, with these few remarks, I request our president to please say a few comments.
Good evening, everyone.
Good evening.
It's really very nice to be back in India and be with our friends after a long, long time. We had been out for a bouse and then it just happened. And this today's program for minimally invasive treatment, surgical treatment for prostate. If I remember during our student days, even TURP was supposed to be a minimally invasive surgery because most of the time it used to be an open surgeries. But as the time has progressed, the TURP has become gold standard, and anything even more patient friendly and minimally invasive things have come in the line so as to call as this one. So maybe after 40, 50 years that we have been seeing in last one, there have been so many things which are coming almost trying to match with the gold standard of TURP, and very good new modalities have come that we will be discussing, and I'm sure we would all learn with it. Thank you very much. All the best.
Thank you, sir. Uttam.
Hello. Good evening, everybody. And I'm sure whoever is joining are smart people because it's a smart learning program. It's a smart class, and it will be, run by the smart people around only. Dr. Rohit Joshi as the convener, moderator, and another three smart guys: Dr. Manohar, Dr. Pankaj, and Dr. Abhishek, of course. So, as per my understanding, so this is missed is in between. The place of missed today is in between the medical therapy and the invasive therapy. So only issues whenever you go to any international conference or any conference that far. So these things are being discussed. What we are going to discuss today, either Urolift or Rezum or Aquablation, these things are being discussed. I don't know whether it is industry driven or not. That Rohit will tell in his comments whether it is industry driven or not, because efficacy wise, little bit less compared to maximally invasive therapy. But definitely there are patients, and the cost is the main issue. So, but still in India, we have a disparity among people who have got a lot of money in one hand, and another hand, they don't have the money. Maybe TURP will be cheaper than all those things. So that leave apart this thing, as per the science goes, it definitely has got some advantages, but it has to be applied for select group of patients. And I think you people, the smart people who have joined today in this class will be benefited by learning these techniques, the new techniques, the smart techniques, as well as their indications. And of course, 1 hour is not good enough to learn all three. I heard Rohit in Bhubaneswar, he was describing that Urolift. Now he has switched over to Rezum. And Dr. Manohar, of course, I have heard him. And Pankaj is from PJ only, and Abhishek. And they're all good people practicing all these areas. And, the knowledge plus experience, that makes this is smart. So not only they have the knowledge, they have the personal experience with all these three procedures. I think that will definitely be an advantage whoever is joining these things. So with these short comments, I don't want to prolong my talk because they are going to talk today, tonight. And thank you very much.
Thank you so much, President Sir and Secretary Sir, for this kind comments. And we look forward to, your ongoing guidance, whether it is about practice, whether it's about science. So we always will remain indebted to you, Lalit Sir, Sujata ma'am, for, your continued guidance. And whatsoever we can do with this webinar, the main intention is to spread the word about this new technology and try to figure out how best we can pinch this kind of technology in Indian settings. So that is the whole motive. And let me take this opportunity. This webinar was supposed to be conducted by Dr. Gopal Sharma. Unfortunately, he had some other commitments. So I am an impact substitute. So I am not as smart as what Uttam told me. I am an impact sub. like an IPL. So I am here as a substitute. So I'll try to justify whatsoever I can do on his behalf. So with that small introduction, let me have a little bit on the subject. So today's topic is MIS for BPH. Now we all know what MIS for BPH is, and today's talk is all about answering three questions: why, when, and how. Uh, but before that, let us start with a disclaimer that we all believe that TURP is the gold standard. In presence of Lalit sir and Uttam, we cannot deny that. And we also believe that HOLEP is gradually become size-independent gold standard treatment options for BPH. We do lots of HOLEPs and TURPs, but this gold standard remains true only if we consider the relief from LUTS component of BPH. But my friends, let's understand BPH has many more components besides LUTS. And what is currently most relevant is the quality of life. Even in cancer and this kind of life-threatening situations, we always talk about quality of life. And that's where I think we as a urologist need to train our own minds to broaden our perspective about BPH and what impact is it has on the elderly population. And when we do understand that kind of quality of life issues and the impact, that is when we think that there is a space for miss even in Indian setting, and that space is as much as the space which is there in this slide. In my own experience, I at least see one or two out of 20 prospective surgical patients who do qualify for MIST. So it's all about broadening our own perspectives regarding BPH. Now, just a introduction for the smart residents, that there are two categories of MIST. One is tissue ablating and one is tissue sparing. And we are going to talk about three of these technologies today. And now let's ask, these three questions to our panelists. But first, let me tell why MIS for BPH. Why are we discussing MIS for BPH? I'll say there are three sentences. BPH is not just about LUTS. BPH is not all about LUTS. And mind well, BPH is not just LUTS. So if we understand these three sentences, then we always will have, a point in our mind that all the patients who come for BPH treatment, we need to discuss things with them. And for that, I would recommend all of you to go through this article, which was a landmark article wherein prostatic urethral lift was compared with TURP, and it was a randomized study, multicentric study across 10 centers in Europe. And what they did was they had validated 6 validated instruments that can assess overall patient's net health and quality of life, and they were followed up for a reasonable length of time. And these were the 6 components which were assessed in that trial. LUTS was assessed in terms of IPSS, erectile function, ejaculatory function, incontinence, quality of recovery, and de novo complication. So when we take only LUTs, the TURP was definitely far ahead than what Urolift produced to them. But in the rest, all 5 parameters across those 10 centers, overall feedback from the patient's part was they chose Urolift over TURP. So this is a kind of study which actually, awakens us from our own fixed mindset. And this is when we offer this MIS for BPH. Our panel will further elaborate on that. And when not to be done, that also will be told better by them. So, how? Now, this is the question that how can we offer? How that there are how many different types of mist which are there. So I'll conclude here, and I'll one by one I'll ask all these esteemed panelists to throw lights on the three most common, effective, and most kind of rewarding minimal invasive surgical techniques for BPH presently. So we have T Manohar from the South Zone, who is going to talk about Rezum. Then we have Pankaj, and he is going to talk about the Urolift, and then Abhi is going to talk about the role of Aquaablation. So first, let me invite Manohar. Manohar has a very huge experience about Rezum. He is doing Rezum here as well as in Oman and so many, I think, Arab countries. And he is probably third person in India who has got this machine on his own. So I think he has got a lot of experience, and we all will benefit from his experience. So Manohar, over to you. Please throw some lights on the Rezum.
Yeah, I thank the ISU USI organizers for giving me an opportunity to share my experience on this topic. So let me straight away go ahead and talk a few important practical aspects. In between, I'll also share some of the scientific issues which are being on the radar in the worldwide. We have varied treatment options. We have 5 lasers to treat prostate. Then there is Urolift, there is Rezum, ITND, Aquablation, TURP, and so on and so forth. And also, not only that, and there is the way it's transrectal, transperineal lasers. They are on the coming, and then there's, I think the innovation is still not ending soon here. And at the bottom line, I think at the extreme end where the genesis of MIST comes from TUVP and transurethral microwave therapy. So 30% in my practice, if I would say practically, these 3 will come into picture of the ITND, Aquablation, I mean the Rezum and the Urolift, but ITND has not caught up very much. But this is just the beginning of the new indications. So what are basically the indications of BPH surgery or complications basically? And there, I think we all know that there are the 5 classical indications for surgery, but with people's preference, I think there is 2 more indications have been added up. Symptom deterioration despite medical therapy, and the patient experience is because that the patients who does not want to have a medical treatment but they request active treatment. So the options are widened up. If you have a male medical treatment, surgical therapy, there is a few indications which we are very happy in doing the enucleations and TURP. There was no problem as such. But I think those are the patients who does not want medical treatment, or they request active treatment. This is the basic genesis if I look at my experience. So the medical risk, as we are increasing in the age group, anesthesia problem, as we have more and more population belong to that. And I think in Bangalore, 70% of the more than 50 years, they have antiplatelet agents. I think we are seeing all these conditions. That's the reason the indications are increasing, the people who are on antiplatelet agents. So these 3 indications are the main thing. And then depending upon the size, there are various options. I think in the bottom line, if you see about the various options have been opened up apart from the enucleation and TURP. So what is this medical treatment? Why this medical management? Why people does not want to undergo medical management? Why this is an alternative we're looking for? Let us discuss. This is very important. 44% of the men older than 65, they take 5 medications of late. You can, our Indian population, I think our lifespan is up to 72 years now. 12% take about 10 more medications per week, and elderly people are greater risk for adverse drug reactions, especially when you take combination therapy. And in case of case control studies among old age people, polypharmacy was found to be an independent risk factor for hip fractures. I think we'll go into that. So basically, the 70% of the patients stop medication in the first year itself, and 50% patients stop medication within 6 months, and 47% medication after 1 year. So because they are not effective or whatever it is. So there are complications. They're like asthenia, dizziness, orthostatic hypotension. We have seen that increased incidence of IFS, especially these patients should not undergo the cataract surgery 1 month before, abnormal ejaculation. These are the problems which you don't discuss. I think anybody who is in the regular physician, if you see ultrasound report of prostate enlargement, you would have written the medical management. But I think the problems are paramount. You cannot do that because of adverse effect. You can see that altered libido, malaise, fatigue, muscular pain, headache, impotence, dizziness, and these are all the issues. I think we need to look back and see what we are doing it. And I think Rohit was mentioning BPH is not always LATs. So this is the where the indicated patient should only be prescribed alpha blockers. Otherwise, number of years of medications also counts. Combination therapy has got drug adverse reactions, retrograde ejaculation, ejection failure, and then loss of libido, dizziness, gynecomastia, nipple pain. And I think to summarize all these things, practically what we see is the nasal congestion. Commonly, if I see in our practice, postural hypertension, they come, and some of them break their bones also. Sexual dysfunction, head injuries we have seen because after taking alpha blockers. Constipation is most common. If you ask them, they will tell you. Affect the ejection fraction, especially those in cardiacally compensated. Nowadays, cardiologists don't like if the patient is on alpha blockers, and if you try to put them on dual alpha blockers, and then over a period of time, if you ask them, the patient started developing tremors, movement disorders, and I think one of the reports which I come across very lately, that memory loss after 7. If you ask the wife of the patient, specifically ask them, is the working? Yes. And if you see that the patient has been taking more than 7 to 10 years of alpha blockers, he is developing memory loss. I think these are all the problems, serious problems, where the genesis of MIST is coming to picture. according to me. So there is a device where studies are going on where you know that this Rezum scores over all this medical management in terms of all this, which I was mentioning, satisfaction of the sex life and ejaculatory function. So the NICE guideline, as in the UK, they recommended, for this reason, they recommended the Rezum as one of the treatment. And I think by this 220, when they started first case in 2017, by the time they have done 8,500 cases, that means there is an acceptance of the patients. There is an acceptance is there for this procedure. So what is this Rezum water pepper therapy? How it is different from, because we mentioned TUNAT, you mentioned TUMT, and there are other heat therapies. It is different way of applying thermal energy to effectively treat lower tract symptoms. Like heat source is the steam is the heat source, and the heat transfer is by convection method, and it is contained within the prostate anatomy, and then this convectively delivered. That means uniformly delivered all the way up to that. So it is a limited energy delivery. So let us understand how does it happen. Steam is contained within the transitional zone, and it is delivered within 1 centimeter of the needle. And no two prostates are the same. I think we know that it always has to be tailored. And I think the treatment is usually in 9 seconds. So it is very fast, very quick, and this is an animation wherein you can see that there's a needle is going there, and then
uniformly disperses through the tissue interstices. The condensation of water vapor releases stored thermal energy. Cell membranes are gently denatured, thereby causing immediate cell death. The vasculature is closed, and there is denervation of the alpha adrenergic nerves within the treatment zone, providing you with an efficient, uniform, predictable treatment. Over time, this ablated tissue is resorbed by the body's natural healing response, reducing the volume of tissue, allowing the urethra to open, relieving lower urinary.
So what happens to the power steam? So here what happens, the water, basically it is, when you put a steam, it is almost 100 to 110 degree water vapor therapy is condensed, delivered into, and the temperature of the prostate is 37. We are injecting steam of 100 to 110. So basically we are heating the tissue to 70 degrees centigrade over a course of 9 seconds. So how does it happen? It's a convection. Convection method is that it's only the 0.4 ml of water. It's water which has been vaporized and steam 2.4 ml, and each treatment delivers around 208 calories of thermal energy, and cell membranes are denaturated by the method of convection and conduction method. We can see that. So the heat source is cell by cell, it is convection which is getting reabsorbed by the body slowly, and conduction is the one which unpredictable cell membrane encapsulation and volume reduction. So these are the two methods. How does it happen? And you can see here the 1 week post procedure, which is the steam has been given here, and it is resolved automatically within the body itself. It will get resolved. So this is here the video of the procedure wherein this is the transitional zone. And when you see that this injection has been happening here, and then you can see that the real-time ultrasound, which is showing that when the needle goes in, and then where the steam, this is the urethra, where the needle is divided. It has been deployed. Now it is deployed into the prostate in the transitional zone onto the one side. And you can see that the area of steam vaporization occurs about 1 centimeter per second over a period of 9 seconds. 1 centimeter perimeter of the 9 seconds. You can see that the action is, so it's about over 9 seconds, 0.4 ml of steam is injected into the prostate, into the different areas of the prostate. So this is the energy contained within the transitional zone. It doesn't spread behind that. No, this is the main article wherein you can see that Kevin McCavery were very extensively studied and gave the insight into the 5-year the benefits and their adverse effects. And let us go into that area wherein the Qmax. You can see that when you give an injection, you don't expect drastic results. You expect the results to be at around 3 months. Yeah, that's why they have written at 3 and 6 months. Unlike in enucleation or QRP, you just the next day you see a Qmax of increasing, but this is the effect is like this, and then get stabilized over a period of time. And when you look at the IPSS scoring again on our 3 months, you see the scoring is some kind of reduction in the IPSS. The patient satisfaction is increasing, improving. So it is basically it is a 3 months duration. All these procedures. And if you look at the ejaculatory dysfunction, I think there is no change in the ejection fraction, ejaculation. function and ejaculatory dysfunction. I think that is the one which has been preserved. But of course, when head-to-head comparison with the Urolift, I think it scores less over the Urolift, especially when it comes to the ejaculatory functions. As a BPH index, you can see that again, the BPH impact index where they studied earlier for the tuna and the QMT. So the same thing is continued for about the minimally invasive treatment. Again, here the 3 months period is the one which is where you can see the improvement of the prostatic symptoms after the procedure. So basically, the study what they designed was 198 subjects and more than 50 years old. Their effective durability was re-surgical treatment is 4.4%, whereas re-medical treatment over a period of 5 years required 11.1% required some kind of alternate medical treatment. And then the improvement of the baseline IPSS scoring is 48%, nearly 50% of them improved, and then the peak urine flow is around 44%. And overall, between 45 to 55%, you can see the quality of life, IPSS, and peak urinary flow improvement. Excuse me. So can it be extended into the median lobe? There was a lot of discussion going on. And then, but of course, this also is, can be done into the median lobe, because as you can see that central zone extension into the median lobe, and then what you're doing is injection into the transitional zone. Here you can separately by the conduction method, 31% of the men with the Rezum pivotal study, they found that median lobe was identified and they've been treated, and it was found that it is useful. You can see these yellow lines which we treated, and you can IPSS scoring, you can see that the symptom score has been improved, and also Qmax in these cases drastically show a significant difference. So median lobe can be treated by a convective vapor treatment, markedly reduces the obstruction from the enlarged central zone. So this has been now been taken in. And of course, we have definitely there is a side effects of this Rezum therapy. Dysuria is an issue, hematuria, there may be sometimes gross hematuria. Even I had one patient, hematospermia, urinary frequency, retention, UTI is suspected, decrease in the ejaculatory volume, urgency. But I think the important bottom line is that number of events which have happened were about 82, which is 212, but most of them are 80-90% got resolved. That's the important point, is that although they have a problem, 90% they get resolved within 3 months. This is not my intention, but then there is a comparative study, although it is not a head-to-head comparison, it is not a proper RCT. But then when they started studying about the pivotal study of the Rezum and the Urolift pivotal study, so the age matching and patient population showed that there is some amount of retreatment rate is around 4.4% in Rezum, whereas the retreatment rate is 11.5% requiring medication, requiring surgical therapy is 4.4%, whereas in requiring some kind of treatment in Urolift is 10.7%, but requiring the surgical treatment is around 13.6% as compared to 4.4%. Of course, it is not a head-to-head RCT, but I think whatever the studies we are taking to the pivotal study and the Rezum pivotal studies. So as the AUA guidelines shows, as it stands today, it's a moderate recommendation, evidence level C grade. The Rezum is indicated for 30 to 80 gram prostate. Again, it's PUL is also used for 30 to 8 gram prostate, but the absence of obstructive median lobe still today it is not included in the AUA guideline. And then, so the conditional recommendation is that evidence grade C, wherein you can use for a median lobe for the Rezum, but not for the Urolift therapy. So the BPH 5-year now treatment for all these missed treatment, which was historically present from Tionide is about 51%, QMT is 21%, Urolift is 36%, and Rezum is 4.4%. So these are the references, and I'll tell you the experience, what we have. I think we have added another 5 cases to my kit now. I think it's in the 36 cases, my experience of doing this in India and abroad. This is the instrumentation technology. It is the whole kit will be available as one kit. So I don't think one need to anything to invest. The generator is the one which can be carried on, and you require one telescope and a camera head is sufficient. Otherwise, the rest of the things, whatever is on the table is available to you with a kit. So this is the short video how it can be done. This is the kit which is available. And this is the telescope which has been fixed. We can do that 30-degree stores, and the wolf can be done. I think Olympus is not able to do it. I found that on the currently, I think stores and wolf, they are able to do it. Probably I have not used the other scope. So this is how you need to have one monitor. You need to have a camera head and then the light source. So the telescope. So then he said 16 French. The instrument is actually 16 French. They put a little jelly. Sometimes you need not have to do cystoscopy if you don't suspect a stricture or any other problem. If you straight away that the instrument is straight away, you can directly get inside. If you know that exactly you are treating with the prostate. So this is how the process, which is easier, and then the way the instrumentation make itself is very vertically oblong, and it just walks in better than 16 French catheter. I mean, 16 French catheter, at least you need to put a jelly and try to push it. This instrument just walks in if you have a little jelly. So my 4-case scenario, which I would like to show you, is large median lobe with BOO, which I showed you previously in this uropathy, and adult middle age who want to preserve the sexual function, not tolerating medical management. And they had these are the case of kind of situations which I've chosen so far. PPH with large refractory to medical management in high PVR, and they wanted to go for any of the procedures. These are the one case which large median lobe was there, and then he was on antiplatelets, and then he basically is a neurosurgeon. I was very intent. I was not wanted to do this case. This was the first case actually. We did it in Bangalore, and then he was very reluctant to want to do any other procedure. He wanted a local anesthesia procedure. So one of my indication is the local anesthesia procedure. We have been doing a lot of TP biopsies, so that's how we have learned doing the pudendal block. Most of the cases we are right now doing with the prostatic block or pudendal block. So we have learned it now. It takes hardly about 10 minutes procedure. Identify the ischial tuberosity and do the ultrasound. And there are now in other places in Oman, I use a nerve conductor study wherein we identify when the needle goes at the indicator gives in the indicator, and then you can deposit the local anesthesia. I think days are going forward where you carry out the nerve indicator, deposit the injection, and start doing the case, and the patient walks in and walks out. This is the post-operative patient who we have done for the median lobe. Creatinine was 1.9 to 1.4, and this is the 2 weeks. It doesn't look very exciting when you see ultrasound, and this is after the 6 weeks. Same case which I showed you earlier. So this is what post-operatively seen, and of course he was feeling better, and 1.3 creatinine has come down. And I was surprised to see his IPS score by 80% improvement, although I doesn't want to give a complete list of the complaints. And then this is, I think I've not put the uroflowmetry in this. It's okay. So this is another 48-year-old male, and he's a patient who had a lot of problem with the medical management, and he has a ejaculatory dysfunction, and ejaculatory function. He's 48-year-old. He wanted to preserve the ejaculation, and he's a small prostate, 34-gram prostate. He was advanced URP, and this is what he had, this uroflowmetry, very poor flow, and with medicines he was not comfortable. Here you see that we have given only 2 treatments in this case, one to the right side, one to the left lobe, and then I just run through the video. I've already shown that. This is the little technical modification where usually you turn this 90 degrees to give the injections 1 centimeter apart. You see that if you really want to give ejaculatory function preservation, now see this I would have turned it to 90 degree, exactly horizontal, assess the 1 centimeter. This is the half centimeter, 1 centimeter from the bladder neck, and it should be away from the Vero. See this normally I would have preferred to give exactly 90 degrees, and then I'm rotating upwards to give it above, rather than I would have given it here on this position. So give it upward so that the 1 centimeter perimeter area does not get into the involvement of the ejaculatory ducts. That's the idea of giving that. Little technical modification, you can do it. 1 onto the right lobe, 1 onto the left lobe. So this is the 9-second treatment. This patient, I think the surgical procedure was over. See that my angle of injection projecting is all the way upwards rather than 90 degree straight like this. So this is the injections, and we have studied that we have done a transectal ultrasound during the procedure, and we can see that effect, which is not this is the transitional zone, and this is the peripheral zone, is still intact here. It is not gone there. Conduction effect is going there, but real convection is only up to the level of the transitional zone. You could see that this is the final report and results, how it worked. It's only 2 injections we have given for the 34-gram prostate. And you saw the flow like this, and this is the flow preoperatively, and then you see the post-operative 6 weeks. He had a good improvement in the 6 weeks, and 3 months, the same patient, same age, and he was keeping 40 ml, and this is 3 months post-operative. And this is how the final, the picture of the uro flow, and he was good. He preserved antegrade ejaculation after 5 months. And this is the patient who had a diabetic hypertension, and then he had a poor frequency.
Manohar, we have to little hasten the things.
Down?
Yeah.
Okay. Then I'll just go
Just
down
hasten
and
it, yeah.
So this is another case where we have, I'll just I'll tell my, they have extended up to prostate to larger prostate volume, but it's not our intention. Right now, we have 40 to 80 gram prostate. And then what is the catheter management is 1 day for 10 cc. That is, if you have 30 gram, 3 days, and you can take the 80 gram for 7 days. But I think a lot of people are coming with more than 7 days. So patient on anticoagulation can be hold on to the blood thinner for a few days, restart the next day. That can be done. We have done it for on a patient who are on ecosprin, and avoid injecting to large vessels. Whole needle very still doing that. Don't move, and procedure 20 fray can be given as like in you do a gentle traction in QRP. So I think coming to the end slide, where in limitation is the atonic bladder, very large capacity, prostate volume of more than 150 ml according to literature. But in my books, I have not done anything more than 55, 60 gram prostate, enormous median lobe, significant renal impairment, Rezum gland requiring more than 15 treatments. And in my books, and I think finally in Indian scenario, those who wants to preserve ejaculatory function and sexual activity, those who are not fit for GR in very high category, those who do not tolerate alpha blockers, patient preference over with improvement by 3 months as a first line therapy for alternative treatment. And then the young adults who wanted to preserve the ejaculatory function and with BOO and their smart moderate set process and Urolift figures. Thank you.
Thank you so much, Manohar. This was a fantastic elaboration of a new technology. Can I ask you one question, Manohar?
Yeah.
Yeah, I have been studying this Rezum. I have been doing this, but one question which bothers me is that the company claims that the whatsoever treatment we are delivering by convection, it stays within the transition zone. Now we all know it's an anatomical zones. Now how do you explain physiologically that 0.42 ml water which you have injected in transition zone shall not cross that zonal boundary and not enter into peripheral
No, it
zone
is.
or,
If
or
you
somewhere
look at
else?
the trial run, when you see this, it spreads across the, it has got some 9 holes on either side. It goes surrounding
Right.
area. So it's not one area where that's the reason why they call it as convection conduction. I think very interesting science it is, because just a water, even I was thinking, I was not a believer of this, because I started doing it because people forcibly asked me to do this procedure. Honestly speaking, I would not have taken that unless the patient would have asked me to do it. People forced me
Right.
to do this procedure, and I've taken up this. And I think the last patient, even I think I showed you the urofrometry, it looks, I mean, it's different. I mean, if you look at ultrasound, it no way comparison to HOLEP. But I think there is patients, I mean, if you ask the symptoms, it's different.
Correct.
It's entirely different.
Yeah, correct. So I'm taking this liberty. I'm showing you a video of the patient which we did just of the sake of what it does. See, this was the pre-Rezum cystourethropy of a patient, same like what Manohar you described. 35, 40 odd grams prostate, and he was having significant bothersome bloods. And this is how his prostate looked like, right? And this was 34 grams. And most interesting part is I was not convinced with this thing, but then I did the resume, and then the thing which I wanted to see was how what impact or what effect does it produced after 21 days. This patient fell to void on 7th day and 14th day, and then 21st day I took his catheter out and he started voiding. And this urethroscopy I did at 28th day. And you look at the cavity. So the moment we cross the Veru, and we can see a very, very good cavity happening where we have given one set of injections. So this is after seeing this, I also started believing into it, and then gradually adopted it. So this is the cavity which is produced by Rezum at the end of 28th day. So my friends, we have to understand that this is not going to give immediate result, and our patients need to be counseled that the optimum effect shall come at least from 14th to 28th days. So I think, Manohar, the first 14 to 21 days are a bit stormy and needs a lot of counseling for our patients. Am I correct?
I think one important caution is I don't do Rezum if the prostate is tender on digital rectal examination. Try to avoid this patient. Otherwise, he will come and eat your brains and chew your brain for 3 months, dysuria, all those things. And I think that is the one, I think, contraindication.
Correct. And what is your antibiotic protocol for Rezum patients?
I mean, of course, in all the patients, we give 1.5 gram of cefuroxime as even whatever endoscopic procedure, the only 1 dose we give it. If it requires, we give Wadhwa for another 2 doses. HOLEP also same thing, 1 dose. Even for any under procedure in our hospital policy is to give only 1 dose.
One last question, come comment, Manohar, that the company is promoting this technology right and left. They are taking their machines to different centers, and I have been reading lots of WhatsApp messages that somebody who is doing it for the first time and they are taking 120 grams, 110 grams prostate gland. Do you concur with this approach?
I mean, right now, I don't have an experience to tell, but I think Dean Alterman has done more than 80 gram. There are people are doing it, but I think long term, we have only 5-year results. See,
Yeah,
what 40, 50 gram prostate TRP is good results. Same result, what we are producing it. What we are talking is the results of equivalent to TRP. Whether you do
right.
TRP, whether you do Urolift, whether you do Rezum for 40, 45 gram prostate, doesn't matter. But the indication
Correct.
is that here, I have not any patient who are under GA. All of them are under
Correct.
period of block. Nobody was there. And then most of them want asexual function, and some of them wanted to stop medical management. That's it. So more
Okay,
than
but
80 gram prostate, I think probably the years, number of years, it's easy to do it instead of the people who are TRP is not easy because
correct.
more than 50 gram, 60 gram prostate. I think you know that only 30-40% of the prostate can be removed even in with the moderately trained people. So there is some kind of issue was there in doing a TRP. So people are moving towards away from there. If they're able to get a hands onto it, I think that's they are going to
But
entertain that.
would you recommend, getting a little
No,
more
I don't
experience and
recommend.
expertise?
As for the guideline, at least now 80 years, I think we should sit in with
ATM
the
is correct.
guideline and then keep our results within that limit. Even I have not extended more than 50 gram right now.
Thank you so much, Manoj. That is really, really a very correct message passed on to the participants. Okay, now moving from Rezum to Urolift, that is prostatic urethral lift. May I invite Pankaj, please throw some lights on what Urolift role, what all Urolift has to play in our practice as far as BPH patient management is concerned. Over to you, Pankaj.
Right. Thank you for the opportunity, and let's see what I can muster up. Some of these slides are probably going to be similar to uh, already seen, so I'm going to try and skip those for keeping time. So I'm talking about Urolift or prostatic urethral lift, which should be the correct term since Urolift is actually a brand name. It's actually a permanent tissue retracting implant. So I explain it to my patients also. It's like stapling the prostate. I think that just sums it up quite easily. So it involves an implant which has 3 components, which has got a capsular nitinol anchor tab, which means the capsular tab is going to be on the outside of the prostate. And this is going to be attached to a PET suture, monofilament suture, which is going to be traversing through the prostate. And then there is a urethral end piece, which is snucking or tugging this tissue apart. And that is placed after adjusting the tension on the suture. So that's what this implant really does. And this implant is actually housed within a 19 gauge housing within a handheld device. And I'll go a bit more about the handheld device in a while. What is important principally is that one is simply trying to retract tissue in the same manner so that a better channel is formed to help void better without disturbing the anatomy. And this is done typically at the anterolateral aspects at 2 o'clock or 10 o'clock. For reasons which include that one would try to avoid hitting both the neurovascular bundle as well as the dorsal venous plexus preserving, and yet creating a channel in the same zone. And therefore, a continuous anterior channel, which is quite different from what we do when we are TURP. We always think, let's do a posterior channel very well and a good runoff. So it's a bit counterproductive, counterintuitive in that sense, but it does do the job. So this is the instrumentation required. It's low cost in its requirement of stuff, but the implant itself, the device itself is fairly highly priced. So it needs a 20 French sheath, cystoscopic sheath, a Storz kind, because this device has a lever lock kind of device which locks here, which locks onto the sheath. So it has to be a Storz type of sheath. And the telescope, so this device goes through the 20 French sheath, and a telescope, a 2.9 millimeter lens, 0 degree lens, which is a longer lens than normal, goes through this device, and because it has to accommodate this portion of the handheld device. So they have also created a custom bridge to make sure to take care of the length, so that one is doing a cystoscopy, that length is taken care of. So that's pretty much what is really required, apart from a camera and a light source and a monitor. Now, a bit more about the handheld device. It's got portions. I'm going to talk about this lock, which is there on the gray portion. If you can see this blue dot on the screen of the device, which is actually a lock. So that's a preventive strategy, so that one doesn't inadvertently fire the device. So once one is actually ready in position to fire the device, one has to actually unlock this and then press the blue tab, which is on top, which actually releases or deploys this needle, this 19G needle with the implant within it, which will go across the prostate. And I'll show some videos to show that. Subsequently, one presses this entire gray tab, which retracts the needle back into this device, leaving this capsular tab and the PET across. And then one tensions this tissue, and finally, once the PET lining is seen as a reflective line, which is called the so-called white line, which is actually just light reflecting back from the 0-degree lens from this reflective PET, as seen as 90 degrees. So it's seen like a white line. And that's when they have a blade, which is activated by the thumb at the back of this device, which will cut this PET, and at the same time, insert this urethral end, stainless steel end, keeping this implant together and retracting the tissue apart. So I'm going to quickly show a video, an animated video, which will probably at least get things started. So that's a cystoscope. It's a wonderful video made by the company, and I've just borrowed it from the net. It's easily seen. So this is to see the inside as well as the outside. So you've got a cystoscope in place. You've scoped. You've figured out how many implants you possibly need. You need to see the configuration of the prostate. And then you come back and you put the device in through it, and you come back and you literally push the tissue away. And this should be away from the bladder neck. And if you notice, this is the needle going in, and it's not at right angles. It's actually in a curvilinear manner, which is why one comes away from the bladder neck, because you do not want to involve the bladder neck. And then you fire the needle and the capsular implant like so, retract the needle back by the gray tab, tension it, and then cut it through. So you place it on one side, you start more proximally, then work your way down distally, keeping about 1.5 centimeters difference at least between the tabs. And depending on the configuration, number of implants would get decided. So you typically start on one side, counterbalance it on the opposite side. But mind you, this is actually in one plane. So you don't appreciate that, and we'll see that better in a cystoscopic view, that you're actually maintaining an anterior chain. So this is the kind of thing you want at the end of the procedure, without cutting anything, just a wider voiding channel, without really disturbing any anatomy. So how does it really work? I told you, it works like, in my opinion, it works like a stapling device. So you've literally stapled the tissue away, and they've done tissue studies which show there's tissue compression, and then this intervening tissue which is compressed gets decreased blood flow, leading to lobular atrophy over about 6 weeks, and eventual scarring, which will be seen at 3 months and 1 year. And the interesting thing is that this is actually seen on the CT. So this is a CT picture on the left-hand side, where you can see both the tabs, the urethral end, as well as the capsular end at the anterior zone of this prostate in this patient, and an MRI, which will show the stainless steel and a ghost effect on the urethral end, but obviously not the nitinol on the capsular end. So it doesn't preclude you from doing an MRI in the future, but it does cause this ghost effect. So if somebody has a tumor in the future in the anterior zone, that could possibly get missed, and that's to be kept in mind. So therefore, the standard thing that this should really be done for a benign disease. However, it has been used for locally advanced prostate cancer, and that's off the book really. But the interesting thing is that these that these tabs can actually be used by the radiologist to actually plan where all they want to give the, so they're like fiduciaries almost, but we're going to restrict to BPH. So what are the actual indications of this procedure? So any BPH who merits therapy, it has to be less than 70 grams, 20 to 70 grams. Larger glands are precluded because the PET might fall short. There has to be only a lateral lobe which is to be treated. Ideally, there should be no median lobe. However, people have pushed that on and treated median lobes, but it is not part of standard care as yet. Of course, the advantage is ejaculatory sparing. So if somebody wishes so, that becomes a clinical indication. Somebody wishes to avoid or is intolerant to alpha blockers, as so well spoken by the previous speaker. Patients who are unfit for a general or a spinal anesthesia, because then you can do this under a local anesthesia with a block, a pudendal, or just a standard periprostatic block would do just as well. And an emerging indication is the acute urinary retention, which is used more commonly in the NHS system in the UK, and we'll talk about that. Absolute contraindications would be the same for any other surgery, which are in acute infections, CA prostate, particularly as of now, and coagulopathies, which are not taken care of because we are breaching, putting this through the prostate. So one will need to stop the anticoagulation for this. So relative contraindications, a prominent median lobe would be a relative contraindication. Not absolute would be a very large one. A high bladder neck will probably not resolve the issue completely, and very large prostate because simply this implant will fall short. I'll just go back to that. So again, just to reiterate that the implant is actually in a curvilinear manner to start with, and then it is tensioned to a straight line, and that's important to understand when one is doing the procedure. So what do the guidelines say? So really, EAU and AU have similar take on this. It has been shown to improve the IPSS, Qmax, and QOLs, but it does not match the TURP even at 2 years. It has low incidence of sexual side effects, which is why it's an indication. The patient should be informed that there is currently no long-term result available beyond 5 to 7 years as of now. It's not been evaluated enough. However, it can be offered to men with interested in preserving ejaculatory function, who have not so large prostates and do not have a median lobe, preferably. And AU has a similar take on it. So let's see one a cystoscopy. Now maybe I just go past. Sorry, I ran through. So I'm going to show this in this case of an individual who is a 60-year-old gentleman who's actually been on alpha blocker for 7 years and not experiencing a great flow. You can see the uroflow pattern. It's a low flow, interrupted stream, prolonged. His voice-wide residue was increasing and has reached about 280 odd ml. He had an SDH earlier. His IPSS was moderate 15, but he was just not happy and his PVR was rising. So an ultrasound showed it to be a 47-gram prostate. He already had started developing changes and he had a right posterolateral wall, a diverticulum, upper tract, so had not decompensated. PSA was fine, creatinine was okay, and a urodynamic showed an AG number of 102. So since he wanted us, actually asked for it, now that's, so it's a grade 2 kind of a prostate, very prominent apical lobes as seen on this. He did have an elevated bladder neck with a bit of a median lobe, but despite that, he was very adamant about going ahead. So we did go ahead. Cystoscopy, otherwise grade 2 trabeculations, both the ureteric orifices were fine. That's the diverticulum, the small 4-centimeter diverticulum with a wide enough mouth. So I wasn't worried about draining. If he drained well, he would drain that too. And then we proceeded with the procedure. So after the scopy, it's the same scope. So again, that median lobe, it's a bit of a floppy kind of a prostate, a bit of edema I felt, although there was no infection because that's a contraindication anyway. And this was the Urolift device placed in the first implant. And I'm right-handed, so I prefer to do it on my right hand, which is the patient's left hand. So you come back from the bladder neck, you look for that groove, and you actually push the tissue, blanch it literally, and try and squeeze it actually. And then once you're sure, you fire the device, and then you can see I've fired it. I'm going forwards, and you'll see this white line, which I wonder if you saw that, which is actually really just the reflection. And then once you see that, and you're halfway through, that's when you cut it through, and automatically it will cut and apply the urethral end. And let's see how it looks on the cystoscopy. So after you go back into the bladder, and then you keep the sheath in, you remove the device, scope it in again, and see the results. So again, you do see that it started moving away. But I was really worried about these apical lobes, and so we'll see what we did about that. So now you go on to the opposite side, go back with the fresh device. So that previous one is defunct. The newer generation, there's going to be a multifier probably, but it's still not in clinical use. So again, the second side, do it on the 10 o'clock position, squeeze out the tissue, make it go lateral, so that, and then you fire the device, needles in place, look for that white line, cut it through, and go back in. So it's a quick procedure, really. But what happens is, if it's a very oozy prostate, then after you've placed a couple of implants, then the vision may go for a toss. You have to be very gentle when you actually do the cystoscopy. You don't want to graze the mucosa too much, because if there's bleeding, you will not see the white line. You won't know when to place it. So you might actually have to wait a while. So being gentle is helpful. So here, if you notice, since it's not a very large gland, kind of pick up that tissue and take it more upwards, and you change the angle, and you kind of lift it out of the way and laterally. And again, look for that white line once you've fired it. The moment you see it reflecting, you cut the thread, you go back in. So if you do notice, the tissue seems to be flopping a bit. So I just felt during this case that there was a bit of floppiness to this less turgor to this prostate, a bit more juicier, despite its not so large size. And I'll tell you why I thought about it, because it bore out clinically later on. So that's now the fourth implant, so that you get an adequate channel. And maybe I can just run it a bit more, because it's going to be more of the same. And then you have a look inside. So this is what was at the end of the 4 implants. But I felt that the apical was still a bit bothersome, and he had a median lobe, unfortunately, which cannot be treated by this particular manner. So I placed another 5th to get a better channel. So a 5th went in. And let me just run through that. And by the end of it, this was the final result. A reasonable, nice channel. You can see it's opened up. And if you look at the comparative between the pre and post, that's a fairly decent channel. And this was, so we actually took out the catheter on day 5, and he went into, and he did not void, much to my disgust. So I put back a catheter, put him onto a low dose steroid, and took it out again in 5 days' time. And this is the uroflow at day 10. And it's a remarkable, nice uroflow. His residual urine was only 57. At 1 month, he is alpha blocker free, antigrade ejaculating, insignificant PVR, and IPSF dropped down to 3. So I've only done 3 cases, similar cases. One of them was a very high-risk individual who had been on a catheter for almost 7 months, was a cardiac survivor. Nobody was ready to actually give him any form of anesthesia. He didn't have a very large gland. And we did this, and he is catheter-free. So not a very huge experience, but that's what it is. This is the original LIFT study, which was prospective, randomized, sham-controlled, blinded clinical trial, multicentric, with a 5-year follow-up. And of course, the PUL was superior to cystoscopy. It showed improvement across the IPS, QOL, and QMAX at 3 years, which was seen at 5 years also at 36%, 50%, and 44%. But in this study, the PVR did not improve remarkably. While the BPH6 study, which was a comparative study, randomized, prospective, non-blinded control between PUL and TURP, it was a non-inferiority study, which showed that obviously IPS and QMAX were way better in the TURP arm. However, it had reasonably good superior quality of recovery, sleep, ejaculatory function, and performance. So it's a trade-off. And I think that's where the patient's perspective becomes more important. And this was actually a real-world experience seen against the lift studies. And in this study, the catheter-free rate at 1 month was 93%. However, 12% of patients needed to come back to the A&E in the first month for various reasons. And the in-house complication rate, that means within the first 24 hours, was 3.4%. Interestingly, retreatment at 1 year was 5.2%, which doubled at 2 years at 11.9%. So it is involved with retreatment. And this is a more large database which saw Urolift, trans-TURP, and PVP. And they found that the average annual increase of retreatment for a PUL was 3.6% per year. So at 4 years, from 5% at 1 year, it went up to 16% at 4 years versus 7.5% for TURP. But interestingly, most patients went in for a reintervention of the same type, which means again a Urolift at 1 year. Some more studies, some showing an intervention rate of 6% per year, but roughly 13 to 16% at 4 to 5 years. Now, complications. So hematuria is the most complicated, most common complication because you're actually going through tissue. You could potentially hit a vessel which you can't see really. So you may need a catheter in. Dysuria does exist for about 2 to 3 weeks, typically. Pelvic pain, depending on more number of implants, possibly higher incidence of pelvic pain, urgency, and even transient urge incontinence has been noted, and UTI in about 10%. So it is covered with a shot of antibiotics. Now, coming to using it in acute retention, I told you that the UK is probably pushing that envelope most in the NHS. So this was the Pulsar trial in which they looked at patients who, and at a year, and they found that on day 3, just about half the patients had a successful walk. And at 1 month, 71%. And this is when they've chosen patients who did not have large glands, who didn't have chronic infection, chronic retention, did not have a median lobe, had been on alpha blockers, and their volumes were less than 100 grams and age were more than 50 years.
Can we just
I will do that. So they found that it works better in younger patients and those who have more efficient bladder voiding efficiency. And similarly, they've even, there's some comparison to enucleation, to 2EB, and they found that in their particular group, the PUL group was higher comorbid and older patient, but lesser complications, lesser operative time, and a reasonably good emptying, intermittency, weak stream improvement of the symptoms with PUL. Thank you.
Thank you so much, Pankaj. That was really kind of, a bird's view about the Urolift. I have one question now. What will be your preoperative assessment protocol to select any patient for prostatic urethral lift?
So the patient should not have chronic retention. Should have.
No, what all you will do, what all you will do before
so a
selecting
standard
a patient?
workup for any patient, you do their clinical scoring or the IPSS, you do a baseline uroflow, you do an ultrasound, you figure out the size, look for an obvious median lobe, which would become a contraindication, in my opinion. You do need to scope them because you do not want a problem up front. You don't want to have a stricture landing in the middle. You do not want a configuration which you can't treat at that time because this is expensive stuff. So you have to scope them. They need to undergo so that you can then counsel them for the possible number of implants. This is expensive stuff. And that's how one would kind of, and this should be a committed patient who has to understand that he is staving off his fantastic uroflows for a medium uroflow and less intervention, and may need an intervention in the future. So this should be a well-counseled patient.
So this is what I am bringing. Can you see the slides? This is the video.
Absolutely.
On the left side, this is my post-HOLEP, a huge fossa which will give a superflow like 35, 40 ml per second.
Absolutely,
and
that
this
is always unmatchable.
Yeah, and this is on the other side, the channel which we create by taking 2 implants. So as a urologist, we need to understand that, we always try to play God to the patient that, if you have come with LUTs for the BPH, We want to give the best of the uroflow, but with that, at the same time, we forget that he might be happy with, a uroflow of say about 18 or 20 ml per second, but he would be ejaculating antigradally. So it is high time as a urologist, we need to stop taking decisions on behalf of patients. Let's involve them more in the shared decision, and then let's understand what their priorities. A person who comes to us at 52 years, 55 years, maybe his priority would be to have a reasonable urinary flow with a maintained antigrade ejaculation. Maybe 10 years down the line, his priority might change. By that time, he may be more inclined for a permanent kind of thing. So I think time has come for all of us to, broaden our perspective and, think more from the patient's side, not from our side. And one more thing, which I have been doing Urolift for a year, more than 35 cases have been done. And what I have,
Fantastic.
understood in this journey of 1 year is, at times, what we are trying is we are unnecessarily taking a burden to give a lifetime cure for a physiological problem. We all age, we all have gray hairs, we do dye our hairs, but it's not permanent. We need to do it every now and then. So prostate is a physiology, it is gonna grow. So if at the end of 10 years, if my urology patient has prostate again grown back and if he requires one more set of implant, it's fine. It is his choice. So I think the time has come. It's all about mindset. If we change our mindset, probably we'll see more and more indication of this patient. This is a controversial statement, but this is what I have learned over 1 year of my journey. Yes,
So
Manohar.
each one to his requirement. I totally agree with that.
Yeah, because
Yeah, Manohar.
Pankaj was telling that there is a contraindication for CA prostate, but I think there is a prostate one patient who had undergoing radiation therapy for a
Yeah.
young patient, and he landed up in the
Unidentified cancer prostate. That's what he said,
Correct.
Manohar. If you are suspecting cancer, then you don't do. You need to biopsy and make sure you're not forgetting
No,
that.
that
So
So
that's
is
what
that
he
as I
is.
said.
said, in a locally advanced where you would possibly think of radiation,
Would you do for
they
a
have
channel?
used it. Yes,
Would you
so
do
they
as a channel?
rather than doing a channel, they have used a Urolift, and in fact, they use these as fiduciaries. The radiation people get to use this as a fiduciary for the outer limit. So they have actually used it, but it is not standard of care as of now. So I mean, you could have a patient who's not locally advanced, you don't want, and is not a candidate for a RARP or a robotic surgery, is a candidate for hormone radiation, but has a poor flow. Now you don't want to do a TUR channeling because then he may become develop strictures. So you could do a Urolift to this guy, get his flow sorted, give him radiation, and you got best. So, but it is not standard of care, is all I'm saying. But it has been used.
Yes, Manohar. I have done in 2 cases, knowingly that patient was supposed to undergo radiation therapy, since he was poor channel like GA, so we did knowingly that it was a CA prostate, and in fact, if you compare benign and the CA prostate, the firmer the gland, better is the lateralization of the gland. So actually, many a times it is the firm tissue. That's what you want when you are doing Urolift. So I think that is, and there are studies for that and people have done that, then we can do it, but only after we have some good experience. So that was a really nice discussion. Thank you, Pankaj, once again. Now, Abhi, over to you. Now, this is all about the aquablation. So over to you, and let's have some basic inception about the aquablation. How does it work, and what all patients can we do this for? Over to you, Abhi.
Thank you. Thank you very much, Rohit, sir. I thank ISU and USI for this wonderful opportunity and acknowledge presence of my teacher, Dr. Sujata Patwardhan. I'm going to speak on aquablation, the power of water. I would like to disclose that I've been a co-investigator for all the inceptual studies of this particular device and were funded by PROSTATE Biorobotics. All being said, the current technologies have limitations, and to overcome these limitations, aquablation has been pitched as an answer, which utilizes intraoperative ultrasound and robotics to deliver heat-free water jet for targeted, controlled, and immediate resection of the prostatic tissue. The principle of aquablation being that it produces a water jet from the nozzle to the farthest point, the velocity and the energy of the water jet keeps on decreasing. This is a mechanical energy. It leads to disruption of the tissue. This disrupted fluffy tissue can be taken out like we do the chips in TURP. The entire procedure is done under transrectal visualization as well as cystoscopic imagery. The resection is carved out based on a software fusion by a computer guided console. So this is how these are the basic principles of Aquabeam. If you look at the water jet has the capability, has the mechanical energy when it is pitched at high velocity. And as the water jet goes away from the nozzle, the amount of disruption it creates goes on decreasing. It is also has a selective nature. That means the more collagenized the tissue, like blood vessels, it is going to cause lesser disruption. That is the premise of using this particular technology. He is Nikolai Aljuri, along with Sulag Mantri. They too, like the famous stories of the American tech world, developed this device in their garage. It was literally a 3 or 4 member team, and then they founded this company. This was the initial team at MPUH which did the first in-human trials for this particular device. And this device, which is the version 2.1 that is available in the American and European markets, looks something like this. It has a conformal planning unit. This unit is something like a radiotherapy unit where you can mark out areas where you have to deliver energy. Along with that, there is a passive robotic arm. This passive robotic arm is connected, it is articulating. Basically, there is a clutch through which you can move this arm in and around. This arm is connected to a motor pack that is in turn connected to the Aquabeam handpiece, which is equal to a cystoscope. This all functionality of this particular device, or the energy, is run through the Aquabeam console. And then there is a tissue collection unit where the suction picks up all the tissue and it is collected in a sock, which is operated through a foot pedal. So the entire energy is delivered through the foot pedal. You can see a few buttons, plus and minus here. These are used to increase or decrease the energy as you go along. So this is a handpiece. The handpiece is disposable. The fiber optic scope is 5.4 French. The handpiece, that means the scope part of it, or the shaft part of it, is 24 French. There is a reusable motor pack. So you have to put this motor pack into a plastic drape and then attach it. This is reusable and can be used. Ultrasound unit. So the BK machine, which was usually compatible with a truss probe, is 8848. So imagine the operating table. From one side, you have a passive robotic arm coming, which is mounted on one side of the table. Onto the other side, you have this ultrasound stepper, which is something like a brachytherapy stepper. This another passive robotic arm mounts the transrectal ultrasound and keeps it in position. So how do you perform this procedure? You do a transrectal ultrasound, which is a freehand ultrasound, then mount the transrectal ultrasound on the stepper. Say this stepper comes from the left side of the table, or left side of the table, that is your left side, and right side of the patient. And then you have the passive robotic arms, which you can mount to the left side of the patient and your right side for a right-handed surgeon. So you can do a freehand cystourethropy, which is always a good idea to do in any kind of a missed procedure that you are doing. Then is the handpiece insertion. So you insert the handpiece, which has a scope which is 5.4 French. It is a fiber optic scope. Once you get into the bladder, then you mount this scope, connect it to the motor pack, and mount it on a handpiece. So you have two things which are mounted. One is the transrectal ultrasound, and above exactly that you have your scope. So they are actually linearly associated with each other. Then you do the angle planning. That is how much tissue you want to resect. That is planned. Press the pedal, Aquablation is done. Evacuate the tissue and achieve hemostasis. So as for other missed procedures, I will just show you a animated film. So that is how you place the handpiece inside. The truss ultrasound is already inside. Mount the passive robotic arm, which is connected with a motor pack. Plan an angle. The angle planning has to be done in 3 dimensions: the length, the angle itself, and the depth. So here is we are placing the depth markers. The maximum depth to which the device can go at present is 23 millimeters. The maximum length that a device can clear is about 7 centimeters. So for any prostatic urethral length more than 7 centimeters, you would require to make 2 passes. So once the aquabeam procedure is done, then you remove the handpiece, introduce your cystoscope, either a 24-French cystoscope with some kind of a bug bee or single functioning electrode, and then coagulate the bleeders. There are multitudes of ways in which you can achieve hemostasis, and I'll discuss as I get to that. So this is handpiece insertion being visualized under transrectal ultrasound. So you see the tip of the handpiece. It is critical to position the handpiece absolutely parallel to the transrectal ultrasound, and then is the point that you get a straight line. Till the point you don't see the straight line, the handpiece is not inside and is not placed at 12 o'clock. So imagine the higher you go with the probe, the more is the lateral angle that you can create for disruption of the gland. So now come to planning of, so you have placed, assume that you have placed the scope inside and it is exactly parallel to the transrectal ultrasound. Now there are points like the nozzle tip. You have to place the nozzle tip exactly at the bladder neck under visualization and under truss guidance. You have to mark the veru and put your maximum length of the channel at the level of veru and mark this all under transrectal ultrasound. Now you have to mark 3 dimensions: the length, the breadth, and the angle. So what you do, length, depth, and the angle. So in the sagittal film, what you do, you place the depth markers. First, you visualize the bladder neck. At the bladder neck, you keep the marker a little high, and in relation to that, you post your depth marker a little deeper as you go towards the verumontanum. Once you come towards the verumontanum, again increase the height. That means the total depth should, like if it, at the deepest portion, it is 23 millimeters. Around the verumontanum, it will be about 18 millimeters. There are 2 salient features that with this software, you can mark the bladder neck and you can mark the veru zone. So what happens is, say imagine this is the verumontanum. There will be a 30-degree angle around the veru, which will be spared, which we call as the veru cut. So the beam will go on one side, fire, then again come back and fire on the other side. That means that some tissue around the verumontanum will be saved. This was done in an endeavor to save the sphincter. And the bladder neck was can also be preserved by marking this. Then come the horizontal angle. The machine has a capability to go up to 210 degrees. That means it can go like an airplane up. But the more you lift the handpiece, the less likely are you going to use this. So anywhere between say 120 to 200 degrees, 10 degrees, the angle can be used. So once you have planned the angle and planned the contour, something like this will come up on your screen. And after this, all you have to do is push a pedal and see what is happening. So you will see the aqua beam is visualized like it is being seen in the screen right now. It uses about 200 to 250 ml of saline per minute, and the total procedure time may be anywhere between 3 to 6 minutes. The total amount of saline used can never be more than 600-700 cc's. So now on the cystoscopy screen, you can see the veru cut where the beam is going only on one side, and then it will come back and go on to the opposite side. You can see a lot of fluffy tissue being raised as the beam comes towards its end portion. And the verumontanum, which is seen as a bright calcific spot, is saved on both the sides. As you finish this procedure, you just have to remove your scope, put in your conventional resectoscope, evacuate all the debris that is there. Don't try to coagulate more. Don't try to resect. Just point, coagulate major bleeders, and come out. The job will be done. So on the left side of your screen is the picturization of clot evacuation, how it is done. So you can see the scope going in and it evacuating. At the end of 1 month, the fossa on the right side is being seen. As it should be, all the pictures in the presentation, try to show you the best outcomes. It is a procedure after all, like any other procedure. It will have the good and the bad. So this is how you can use a ball. You can do pinpoint coagulation using a loop. A lot of saline enters into the tissue. So once lot of saline enters into the tissue, it is difficult for any energy to work. Even the bipolar doesn't work well. During developing the hemostasis, we tried many methods. We just used a bladder balloon, that was a donut-shaped balloon that sat across the bladder neck. We gave traction for a few hours and just tried to do hemostasis using this. That also tended to work well. Another technique we used was a prostatic balloon. So the donut-shaped balloon would sit against the bladder neck, and then we would inflate the second balloon, which was the prostatic balloon, in a specially designed catheter to about 10 cc's. So this is how we use the double balloon. Another thing during the development that we tried was a catheter tensioning device. So like we use strapping in a conventional TURP, we use this catheter tensioning device. The arches of the catheter tensioning device, which we call the CTD, would be placed against the pubic bone, and you could give a tension from 100 grams to 1400 grams. So, bladder neck traction was given in 98 patients. Intraprostatic catheter was used in some patients. And we tried to do this particular arm of the study absolutely without cautery, and it tended to work. But probably it was difficult to replicate. We used hemostasis. This is a 5-channel balloon, 5-channel catheter. We used some flow seal and other hemostatic agents into the prostatic fossa. This also did not become the standard of care. So this is how we would use some amount of flow seal while the development of hemostatic technology using Aquabeam. And these are still being used off and on. But the most conventional method still remains you enter with a resectoscope and then do point coagulation. Do not try to resect. If you try to resect, then there is a bigger problem. So this is a comparison of the same patient after about a reasonable time. So the initial studies which allowed the FDA approval included about 364 patients and were across the continents and countries. We did the first in-human trial and the first 100 cases in the world. Mean prostate size was about 48, median lobe was present in 50% of the patients, and mean PSA was 3.3, pediatric Qmax 77. We found that there was a 21% decrease in the IPSS, 21-point decrease in IPSS. The Qmax increased by significantly by about 9.1 mLs. Then QL definitely increased, and the PVR decreased by 77 ml. The detrusor function increased and the prostate size decreased. Major bleeding events requiring transfusion were 2.5%, and they were seen in glands for more than 80 grams more than the rest of the population. At the second half of the study, we included all comers in our study, which included glands up to 150 grams. The operative time was about 35 minutes. The resection time, 3 minutes. 10% hemoglobin drop in first 50 cases, which significantly decreased a little later. 1.8 days was mean catheterization time. It is a technology that combines robotic platform with high pressure water jet resection. The patient outcomes are definitely favorable, comparable to TURP, as has been proven in the Water 2 study. Adverse events are comparable to other techniques. Procedure time, that means the ablation time, is significantly less. The amount of saline use is significantly less. The blood loss in the initial learning curve was more. There's no retrograde ejaculation, no incontinence or erectile dysfunction. Better orientation with anatomy on truss and understanding of dynamics helps you get through a good early learning curve and deliver a good channel. Advantage of this procedure is that it is quick, has short learning curve, and training and mentoring is easily possible. This was our initial work in 47 patients, with which we could prove the safety and efficacy of this particular technology, and also the fact that it preserved the bladder neck and retrograde ejaculation and erectile dysfunction was prevented. The Water was a double-blinded RCT in 2:1 randomization, which actually established the role of this particular device and led to its FDA approval. Presently, the device is FDA approved, CE mark, has 2 RCTs in and 5 multicentric trials. The limitation of this device is commercially available in Europe, US, now in Australia, not in India. The price that is being pitched at is about 2.25 CR. The handpiece insertion, particularly, I found is very, very challenging because the prostate gets lifted once the truss probe is inside. This is a more invasive procedure than Urolift or Rezum. So there are occasions in which you can get into bleeding, unlike other two myths. The functional results from a multicentric experience are promising. This device is already available. Operative time is significantly less. Bleeding is equivocal. Complications are comparable. And clinical and procedural outcomes say that it is here to stay. The grade of recommendation presently for the use of this device is grade C by EIU. Thank you for a patient listening, and I invite you for the 5th Youth Conclave at NPVH.
Thank you so much, Abhi. Seems to be a very promising technology, but any promising technology comes at a price. So I think the price is a big issue. But I have one small concern, Abhi, that with the kind of resectoscope and all that which we need to do after the water jet therapy, does it really qualifies to be a true mist? That is my concern.
I don't think that it is really a mist. Yeah, I don't disagree with that. The only advantage it offers, why it is being pitched as a mist or has been put in that subgroup, because it prevents retrograde ejaculation. That is the reason that it is being put. And why does it principally prevent retrograde ejaculation? Because of the differential action of the water jet. The water jet does not damage the collagen of the bladder neck. That is the hypothesis. But it is a significantly invasive procedure. Potential of blood loss is significant in this procedure.
Correct. So as compared to Rezum or Urolift, it is little more invasive.
Yes, but also one thing is that this is a one technology which in an RCT has been found comparable to TURP.
Correct.
So that is also there.
Correct. Okay. Thank you so much, Abhi. Now,
Thank you, sir.
after the 3 brilliant talks, I think it is time for me to have learn something out of this. So this is what I have learned, and this is what message I could decipher from all these brilliant talks for all 3 gentlemen. That we need to agree on that myths are not substitute of laser, prostatectomy, or TURP. We all need to agree on that. The selection of patient is of very, very utmost importance, because then only we can have all the outcomes which has been depicted in various series, and we can reduplicate those results. Second thing is, we should never think about this therapies as the wonder therapies which are coming and which will be free of all the complications. These therapies come at a cost, and they also bring certain unique complications. So we need to understand that, and if we understand that well, I think there is a scope for these therapies in coming years. With that note, I take this opportunity to acknowledge the presence of our past ISU chairman, Arun sir. He is here. He is traveling, but still his enthusiasm is like always, and he is still with us on his mobile. Thank you so much, sir. And I think Sujata ma'am, I hope I delivered to whatever the responsibility was headed over to me, and we also recognize Gopal's efforts in putting this show. Over to you, Sujata ma'am. And thank you so much, my panelists.
Thank you,
Thank you
sir.
very much.
Thank you very much. Thank you, Rohit. Thank you, Dr. Manohar and Dr. Wadhwa and Abhishek. Definitely, I think there will be a time and place for this therapy as we are getting more patients who are having multiple problems, arrhythmias, and unfit patients who are on all warfarin and so many other drugs. And I think there will be a place for minimally invasive techniques, especially under local anesthesia. And it's time that if it could be made a bit cheaper, I suppose it could be
Right.
used more widely. So definitely, thank you very much, Rohit, for coming and pitching in at the last moment, and thank you all speakers for your efforts, and all the attendees. Thank you, Chawla sir and Dr. Uttam Meti and Dr. Lalisha. So I think we'll call it a night, and
Yeah.
see you for the next webinar. Thank you and goodbye.
Thank you
Thanks a
so
lot.
much. Thank you
Great.
so much, all friends. Happy learning. Stay safe. Bye.
Thank you.
Bye.
Thank you.
Bye.
Great job.
Bye, Bye,
Bye.
Abhijit. Bye.